Alright guys, today we're going to talk about reproduction. So there are two types of reproduction that we need to address. One is asexual reproduction and the other is sexual reproduction. Now asexual reproduction means there's one parent, and when that cell, because it's normally, when we're talking about the parent, normally it's just a cell, is going to divide into two cells. These two new cells are going to be exactly the same as the original. They're going to be identical. This is asexual reproduction. Now there's parts of our body that do undergo asexual reproduction. Okay, most of our body cells do this to repair, to grow, that sort of thing. But sexual reproduction is where there's two parents. They're going to produce a unique offspring. And the way that they're able to do this is they go through the process of meiosis, where we're going to take that one cell, but we're going to divide it two separate times, creating four unique, what we call gametes, okay, or sex cells. Those cells then are going to have half the number of chromosomes. So then when fertilization happens, where the egg and sperm come together and fuse, that restores the number back to the diploid, and we have a new individual. This new individual is very unique. Now, production of a new individual is the total process from conception to delivery when we're talking about human reproduction here. Now, with this whole idea of meiosis and fertilization, in order to have sexual reproduction, we're going to have some special structures. These special structures are gonads. The gonads are the sex organs, which we're going to review in just a minute. And then we see that they're going to produce gametes, and gametes are the sex cells. All right, and so there's these special structures in the body that are going to allow for meiosis to take place in order to create these gametes, which are egg or ova and sperm. Now guys, conception, before we get into the anatomy, conception is when a sperm fertilizes the egg. Okay, we call that the time of conception, when the sperm actually fertilizes and penetrates the egg. The normal gestation period for humans is going to be 40 weeks. A lot of times we call this 9 months, but it's actually closer to 10 in the sense that it's 40 weeks. Now gestation is going to be different based on what kind of organism you're looking at, but for humans it's 40 weeks. So let's take a really quick look here and review some of this anatomy part of reproduction. Now, for the male reproductive system, the whole purpose is to produce sperm, the gamete sperm. Now with this, the male's reproductive system is tied in with the urinary system, which you can see here in this picture. So the gonads in the male are going to be the testes. The testes are going to produce the sperm, but the sperm then has to travel and be able to be released into the female through the penis. Now when we look at this, it's going to do this through a system of ducts and tubes. These are going to be things like the ductus epididymis, the ductus deferens, the ejaculatory duct, and then the urethra. We see there's some accessory glands that work in here that are going to help with the production of what we call semen, because the sperm needs some help in order to be able to find the egg, because it's going to have this journey once it gets in the female. It has about 3 days to find the egg. And so with this, we need semen to be created. This will help protect the sperm from the female's hostile environment of the uterus. It'll also help be able to provide them energy, okay, in order to be able to move, because the sperm has that tail for it to go back and forth, that flagella, in order for it to swim. These accessory glands are like the seminal vesicles, the prostate gland, and the Cowper's glands. There's some supporting structures here, and this is the penis and the scrotum. Okay, the penis is going to help deliver sperm, but it's also going to help remove urine from the body. And then we see that the scrotum is the pouch that holds the testes. Now this is important because the whole idea of producing good amounts of sperm means that these testes need to be at a lower temperature than your body temperature. So this is why the scrotum is found outside. Okay, it's found outside in order to have optimal sperm production. So when we talk about infertility or issues with sperm production in males, one of the first things they may look at is, are you wearing clothes that are tight that pull the scrotum up towards the body with the higher temperature? That could be affecting the production of sperm. Now also recall that these testes don't only just produce the sperm, they're also going to produce several hormones, and specifically testosterone, which is going to give the the secondary male sex characteristics. Alright, so now let's take a look at the female reproductive system. Now the female reproductive system is not tied into any other system like we see with the males. The males have the urinary and reproductive together. When we look at females, it's separate, and it's going to have twofold reasons or functions when we talk about the female. It's going to produce sex hormones and those functional gametes, or those ova, just like the the sperm is produced with the testosterone in males, but the female reproductive system is also going to protect, support, and nourish that developing embryo and the newborn once it's been delivered. So we see that it's going to have a kind of larger role in this whole idea of reproduction. Now, when we look at the female's system, we see we have the ovaries. The ovaries are the gonads, and this is where the ova or eggs are going to be produced. They are then going to release those eggs, and they're going to travel through the uterine, or what we call the fallopian tubes. These tubes are going to almost like suction up the egg like a vacuum, and it's going to take them and let the egg travel towards the uterus. The uterus is the main structure where implantation of a fertilized egg is going to take place, and that's where the embryo will develop. The vagina is the opening, okay, and to the outside when we talk about with the females. And with this too, there's going to be an area called the cervix, which is the connection between the vagina and the uterus. That cervix is that opening that's going to have to dilate in order for delivery to take place. We also have the uvea, which is the outside part, the female outer part of the external genitalia. Okay, this is going to have several structures to it. It's going to have the labium minora, the labium majora. Those are going to be what we consider the lips, okay, of the external genitalia in females. We also see the clitoris. That's also going to be present there. There's some supporting structures as well that are going to produce some lubrication that's going to help with sexual intercourse in order to take place. These are going to be certain glands like the Skene's gland and also the Bartholomew's glands. These are going to help with secreting a mucus, and it's going to also help with sexual arousal and intercourse. We also see another structure that's not pictured here is the breasts. The breasts in females are going to have another role, and this whole role is to, of course, nourish the newborn child if breastfeeding can take place. So let's look at the physiology when we talk about reproduction. Well, the whole point is formation of reproductive cells. Now, of course, they also produce hormones, which are part of the endocrine system, but a lot of those hormones are in relationship to the ability to make these reproductive cells. Now, this process of making egg and making sperm is called oogenesis when we're talking about the formation of egg, and spermatogenesis when we're talking about the formation of sperm. So let's talk real quick about spermatogenesis first. So when we're looking at spermatogenesis is where we're going to take a spermatogonium cell, which is going to be the basic cell that has the genetic information for that particular male, 46 chromosomes, and it's going to go through a process of meiosis. And when we look at meiosis, it does go through the process twice of division. So we go from dividing, and we now have 2 cells, and then those 2 cells are going to divide, and then we get 4 cells. By the time we get to the end of this idea of meiosis 2, we see that each of these new cells only has 1 set of chromosomes. So half of 46 would be 23. So they each only have 23 chromosomes. So this is half of what we need to have a new individual. This sperm then is going to go through the process of maturing. It matures a lot of times in the structure called the epididymis. The epididymis is going to allow for also quality control to take place. Does this sperm head, is the sperm's head made correctly? Does it have the midpiece where mitochondria are present in order to supply ATP? And is the flagella functional? Sometimes that flagellum is not going to be functional, or they have too many of them. So this is where the quality control takes place, where they may recycle some of the sperm that is not necessarily going to pass inspection. Once the sperm is matured, it's going to then enter and go through those vas deferens. Those vas deferens are the tubes that are going to lead it up into the ejaculatory duct. Now remember that a lot of this pathway is going to be where they're adding different things to help with the creation of the semen. This is going to add more volume, but it's also going to have an alkaline fluid, which is going to help to monitor and buffer the pH that urine normally creates, since it's going to be traveling through the same tube, the urethra. We also see that it's going to produce and give off sugars like fructose, citric acid, and other things, and this is like packing the sperm a lunch in a sense, in order to be able to utilize those particular components to continue to generate ATP. There's also going to be some different fluids that are present that are going to help the sperm be able to, the semen to coagulate once it gets inside of the female, so the sperm has the best chance in order to go and then find the egg. So survival of the fittest starts right then because thousands of sperm get released at one time. All right, and so the sperm that gets to the egg first and can actually penetrate it and fertilize it, that's when we see that conception takes place. So now let's talk a little bit about oogenesis. Now, oogenesis is going to look similar to what we saw with spermatogenesis, but there is going to be a major difference. So sperm is one of the things that starts being produced at puberty, and it continues to be produced throughout the male's lifetime. In females, this is not the case. A female is born with the number of eggs that she's going to have. These eggs are going to be suspended in part of this meiosis that we're talking about, specifically in the part where they're lined up in the middle and metaphase, where they're ready to split, but they're not quite there yet. They're going to sit in that area kind of frozen in time until puberty does hit. Once puberty hits, though, a female is only going to release 1 to 2 eggs unless they're stimulated by more hormones, like when we talk about fertility treatments, things like that. They're only going to produce 1 to 2 eggs each month. Okay, these are going to be released, potentially be fertilized, and that's what we see happening until the process of menopause takes place. When menopause happens, the female stops this process of oogenesis. So if you look here, we see that we do start with an oogonium, so that's the stem cell type of thing where again it has 2 in. It's going to divide, and when it divides that first time, we get that in that takes place. Now, when we look at this, guys, you'll see that this division of the cell is not equal. One cell is a lot larger than the other. And the reason for this is the egg has to supply more things than the sperm. The sperm is only providing the DNA from the dad, but the egg is going to supply the DNA from the mom, but it's also going to supply all the organelles you need. Your rough ER, your smooth ER, your Golgi, your mitochondria, all of those things come from your mom. So the egg is going to have all those present. So there's an uneven kind of separation and cytokinesis that takes place. When this occurs, that one larger egg, one larger cell is going to then divide again, and again it's going to divide uneven to where really only 1 egg is formed instead of the 4 that we saw with sperms. 4 sperm were formed from each stem cell. We don't see that here. We have 1 egg that is going to be released. Now this egg is unique, and this egg is going to have 23 of the chromosomes. So when the egg and sperm fuse together, like you can see in this picture, it's going to restore it back to that 2N. 23 from mom, 23 from dad. This whole process that we're talking about here is going to be related in females to that menstrual cycle. The menstrual cycle is a cycle of not only this whole idea of production of an egg and releasing an egg each month, it's going to be a cycle of hormones, which you can see here, as well as a cycle of what's happening within the uterus in order to prepare for potential implantation. So when we look at this, there's an ovarian type of cycle and there's a uterine cycle that's both taking place. This monthly cycle lasts about 28 days, so that's why we call it kind of a monthly cycle. It is controlled by these hormones released by the hypothalamus, the pituitary gland, and the ovaries themselves. We can see that there is going to be a stage 1, or this is the menstrual stage. In this picture, it's shown as menses. This is the shedding of the endometrium, the inside lining of the uterus, and we see that there's going to be a decrease in estrogen and progesterone hormones that will take place to allow this to happen. What happens here is we're shedding that lining in order to start the process over because implantation did not take place. All right, so this is where the bleeding with some tissue and that sort of thing happens. We then go into stage 2. This is the follicular phase. This is going to also be known as the proliferative phase. This is pre-ovulation. This is where the ovaries are going to start creating and getting a follicle ready. The follicle is going to be where the egg is going to finish its process of meiosis, and it's going to get ready to be released. This is also controlled by some hormones, specifically FSH, which is follicle stimulating hormone, and estrogen. Now, stage 3 is when actual ovulation takes place. Now, during this time when this ovulation is getting ready to occur at the ovary side, the uterus is also preparing for potential implantation. And so we see that endometrium layer is going to start being replaced here, getting ready for it to nourish this egg. So ovulation happens halfway through the cycle. So if it's a 28-day cycle, this would be right around day 14. The ovum is expelled from the ovary. It actually is going to burst out of the ovary. Now, there's going to be a sharp spike in estrogen as well as LH, which is luteinizing hormone at this particular stage. This is what actually triggers ovulation to occur. And guys, since it's bursting out of the ovary, some women actually can feel that they're ovulating. This then leads to the next stage, which is going to be the luteal phase. Also in this phase, looking at the secretory. When we look here, this is where cilia within the fallopian tubes are going to move the egg forward towards the uterus. This is, if pregnancy is going to take place or fertilization is going to take place, this is where it's going to happen. Okay, fertilization is going to take place normally within that fallopian tube. It propels the egg towards the uterus. We do see there's an increased release of estrogen as well as progesterone, and this is because these hormones are needed in order to sustain a pregnancy if implantation does take place. If that egg is fertilized, implantation does take place. That's going to be where we now have a zygote, which is a fertilized egg implanted, and pregnancy then results. So guys, this is what we see happening a lot of times when we're talking about this ovulation and this whole idea of potential fertilization. So the egg is released from the ovary, like you see here. We see the sperm comes in contact and one sperm fertilizes the egg. The egg then continues its travel through the fallopian tubes, already starting to divide through mitosis, asexual reproduction, in order to create more cells, and then we see implantation will take place. Implantation can take place anywhere between a couple of days to about 9 days after fertilization takes place. Now, this brings us then to what we would consider the pregnancy. So when we look at the pregnancy after implantation takes place, we do see that there's an area from weeks 3 to 8 after fertilization that we call the embryonic period. The embryonic period is the differentiation of all the body systems that's going to occur in that little bitty tiny baby at that point. The organs are going to be made here. It's really important that during this time frame that the mother avoid exposure to like toxins, alcohol, tobacco, radiation, and even certain types of infections, because it could actually cause mutations and abnormalities to happen to where development doesn't occur correctly. Okay, it can end up causing like heart issues or brain issues or things like that, because that's when these organs are developing. The fetal period is after that, 9 months until actually delivery or birth. We see that this is going to be a significant growth phase. They're less susceptible to some of those toxin stuff because the organs are already formed, but they are growing a lot during this particular time. You can also see that this prenatal development is important in the whole point of like taking prenatal vitamins, that kind of thing. We do see that there is going to be a certain point that survival rate is going to be better if we can make it to a certain point in the pregnancy. Okay, but this is just kind of showing you what that kind of timeline looks like for that 40 weeks. Now guys, if implantation does not occur, okay, when we go back over here, if implantation does not occur through this, the egg does not get fertilized, we do see that the cycle then will continue. We'll get back into the menstrual cycle, and the 28th cycle will start over to get ready for the next month. Okay, and so we do see differences in what happens after this ovulation if implantation does occur versus if implantation does not occur. Did pregnancy happen or did it not happen? Okay, we're going to see that if pregnancy happens, we're going to have to go one way, but if it does not happen, then the cycle just continues through its normal menses. All right, so let's talk about some variations that can happen with this reproductive system. One being infertility. This is a problem sustaining a pregnancy to term. Okay, when we look at infertility, it's not being able to get pregnant despite having unprotected sex. So there's a number of factors that can come into play here. There could be genetic problems like Klinefelter's or Turner syndrome. Those are normally going to cause the individual to be infertile because they have an abnormal number of chromosomes. It could be due in females due to presence of certain STDs, hormonal disorders in females, abnormal reproductive organs, the process of endometriosis, which is going to be where that endometrial layer is not being formed properly. It's actually like precancerous in that sense. Scarring or blockage of the fallopian tubes. This can be done due to untreated sexually transmitted infections. It could also be due to potential like apoptotic pregnancies, where a pregnancy implants in the tube, the fallopian tube, instead of in the uterus. Okay, so there's a number of things that could scar up those fallopian tubes. And then also development of vaginal antibodies that can kill the sperm. Sperm is going to be a technical invader to the female. It doesn't belong. And so if the female develops these really strong antibodies against sperm, it could cause the sperm to be destroyed before they can find the egg. In males, we see the presence of STDs could also affect their fertility. It could also be chronic infections, not just STDs or STIs, but it could be due to like urinary infections, because those are together. It could cause a blockage. Structural abnormalities, hormonal imbalances, and then also environmental hazards like radiation, but also temperature, like we talked about earlier. If the scrotum's pulled up and it's too hot, sperm production may be affected. Now, there can also be problems when we're looking at this whole idea of infertility or fertility issues, is the maintaining the pregnancy. So problems sustaining the pregnancy, they can get pregnant, but then keeping the pregnancy viable is the problem. A lot of times this is going to be due to maternal and fetal complications. Some of these complications take place in the first trimester and others take place in the second or third trimester. But we do see a lot of times that problems with sustaining pregnancy deal with the production of progesterone. If progesterone levels drop too drastically, the body thinks that pregnancy did not happen and it starts the menstrual cycle over again. This causes a type of miscarriage to occur, a natural type of abortion. So during the first trimester, there's some complications that can happen due to infection. Some of these infections are things like rubella, if the mother's exposed to chicken pox, also like toxoplasmosis. Toxoplasmosis is a type of protist that you can be exposed to from cleaning out the litter box from your cat. This is why pregnant women a lot of times are told to not do that. We also see that it could be an ectopic pregnancy, which is again where implantation takes place in the fallopian tube and then not the uterus. There could be a trauma that happened. There could be actual like physical trauma that caused them to not be able to sustain the pregnancy. And then of course it could be due to just a normal miscarriages. Miscarriages do happen, and a lot of times it's because there's actually a genetic issue. Okay, there's a chromosomal problem and the baby would have never been able to develop properly to begin with. And so during that first trimester is when a lot of that may happen. In the second trimester or third trimester, we see some of the complications could be fetal, congenital, or chromosomal abnormalities. If they're able to survive that first part, we could see complications for things like Down syndrome, Patitu's, Edwards, where there's still an abnormal number of chromosomes, but we do see development is still continuing. Other congenital issues could be things like spina bifida. Okay, there could be things that we're noticing. There could be maternal systemic conditions, like if the mother has gestational diabetes and she's not taking care of that, hypertension, high blood pressure, preeclampsia. All of those are things that the mother is experiencing, but the baby would be affected. We also see certain infections could also be a problem. Preterm labor could occur. This is going to be where we see premature rupture of certain membranes. And so this could mean that they start the pregnancy because their water broke too early, that kind of thing. We also see there could be placenta previa, and this is where the placenta is down at the bottom and it actually gets starting to get pushed out through the cervix. Okay, the placenta is supposed to nourish the baby, and if there's a rupture of that placenta, it could cause complications. The abrupto placentae, well, that's going to be where it ruptures. Fetal distress can occur, and fetal distress can happen in a number of ways. Not getting enough oxygen. It could also be there could be like a kink in the umbilical cord, or it could be wrapped around the child's neck. And then we also see there could be intrauterine fetal death that can occur, and then we need to make sure that we deliver that baby, get that out of there, and so that necrosis and issues don't happen within the uterus to where it could affect future pregnancies. Now, there are some consequences when we talk about infertility. A lot of these are going to deal a lot of times like psychological issues when we talk about this. There's going to be stress if they're having difficulty getting pregnant, anxiety. There could even be grief, especially on the mother's part if miscarriages keep occurring, because a lot of times they may feel like it's their fault when it really may not be. We also see complications of pregnancy could be fetal issues. There could be stress to long-term health problems on the fetus. These could be genetic and congenital. We also see that we could have fetal distress, which is due to like abdominal trauma that may take place, like with a car accident. We do see sometimes trauma or other things that the mother deals with could cause premature infants, like premature birth. This could cause developmental delays as well as intellectual delays, even some disabilities, cerebral palsy or problems with sensory integration. I have two, well, technically one major premature child. My firstborn was born 7 weeks early, and she was in the NICU for about 6 weeks after that. And we did deal with some issues, some complications. My placenta threw a blood clot. She had the stroke instead of me. She saved our lives, but she does have some brain issues that we have to constantly monitor. But if you were to meet her, you would never be able to tell. We do see that there is going to be some psychological issues or consequences for the mother. Lacerations to the peritoneum can happen during childbirth. We also see postpartum type depression or hemorrhaging, and it could even result in the death of the mother if these things are not taken care of quickly, especially with the hemorrhaging that can take place after birth. They talk about how women go to death's door to bring a life into this world, and there's some truth behind that. It's very taxing on the body, and there are lots of complications that could occur. So risk factors. When we talk about risk factors for the whole idea of reproduction or even pregnancy, we see adolescents are a very high risk group. And this is due to the fact when we talk about pregnancy or infertility, it has to do with their decreased nutrition they tend to have. They a lot of times are anemic. They're more susceptible to infections, depression, social isolation, preeclampsia, we also see that they can end up having premature births. They may be more often to have C-sections instead of natural births. So there's a lot of risk factors that can go into play for the developing child, but also for the mother. We also see some biophysical factors. Biophysical factors are, so some genetic counseling may be done even before pregnancy or during pregnancy. Nutritional factors need to be addressed. Or if the mother has some medical issues, kind of like diabetes or hypertension or some sort of psychological issues where they have to take medication like depression or anxiety, seizures, those types of things could ultimately affect the baby. There could also be some obstetric disorders, like if you had endometriosis, or if you have some issues like with the uterus being in a kind of different position or the placenta not formed properly. There's a lot of different biophysical factors. There's also some psychosocial factors like smoking, excessive caffeine intake. These are things a lot of times we use to try to cope with stuff. Alcohol intake, drug use, spousal abuse, stress, anxiety, and depression could all be factors. We also see socio-demographic, low-income individuals that are higher risk. Decreased prenatal care is part of this. If they're younger than 15 or older than 35, there's going to be complications. Marital status could be a complication because of the stress of maybe being a single parent, the other person not in the picture. We also see that there could be the location, urban versus rural areas. There's pros and cons kind of either way you look at this. If you're in a rural area, there may not be as much pollution or things like that, but you may not have access to medical care like you would in a more urban area. We also see race and ethnicity could also be potential risk factors. And a lot of times this is going to be tied a lot of times to their social status in the sense of low income, things like that as well. There's some environmental factors, industrial pollutants, radiation, chemical exposure, if you have certain infections that you're exposed to during pregnancy, drugs, and even stress. So when we look at the assessment, when we're talking about reproduction or even kind of like the anatomy and physiology of the reproductive system, we want to take a history. This history should include their sexual history. With sexual history, it could be based on like how many partners have you had, because this could be part of the reason of having some complications or a potential increased risk of STDs. We see contraceptive history. Have you taken contraceptives before, in the sense of were you on the pill? Did you have like the depot shot, that kind of stuff? Surgical history, as well as your menstrual cycle. They want to kind of map that out. They'll ask you a lot of times, when was the last time, what was the date of your last menstrual cycle? It's to try to map that out. And also your immunizations, because some infections, if you're exposed to while you're pregnant, could cause issues. But if you are currently, your immunizations are current and up to date, they're not as much of a problem. We also see that there's going to be the exam. Oh, and with the history, there's some subjectiveness that comes in with some questions we need to ask. We need to look at if they are pregnant. Is there morning sickness that's happening? And remember, morning sickness does not just mean in the morning. It's like could be all day sickness. Are there changes in their breasts? Increased sensitivity, urinary frequencies, are they experiencing Braxton Hicks, and also are they feeling the baby? At certain points we need to be able to feel that baby, and if they stop feeling it, there could be something going on. An examination needs to be done. We need to look at their vitals. One thing specifically we want to look at when we look at this is their weight. We also want to look at their blood pressures. Blood pressure is a big deal because if blood pressure starts to increase greatly, this could be an indication of preeclampsia. We also will check for softening as well as compression on the lower uterine segment, as well as softening of the cervix. This is why they'll check. Okay, they want to see if you are dilating or if there's a softening that's taking place, as well as checking for breast changes, and this is to help with the whole idea of breastfeeding. Ultrasounds are used a lot of times in order to observe the fetus. Okay, when we look at this, we want to check out the fetal heart rate. We want to check out their anatomy, making sure things are growing and happening like they're supposed to. There are some other tests that they can do. There's genetic testing. There's glucose screening. Maternal blood tests can let us know a lot of information, and actually even more so now earlier on, where we can find the gender out even before that 20-week or 18 to 20 week ultrasound. An amniocentesis may need to be taken. This is where they take some of the amniotic fluid and they look at the genetics of the baby. We would want to see if the mother has gonorrhea or chlamydia by doing cultures, and also be testing for group B strep. Now the reason being, especially we look for certain diseases here, is because they can affect the child as it passes through the birth canal, and it could put them at higher risk of developing complications, especially when we talk about gonorrhea and chlamydia with their eyes, to where they could go blind. We want to see there's monitoring. Monitoring is going to happen once a month during majority of the pregnancy, during the first and second trimester, and then every 2 weeks starting at week 28. At week 36, we start to be monitored once a week. Now this could be adjusted based on if it's a high risk pregnancy or if they notice some issues that are taking place. So management, when we look at the whole idea of primary, when we're talking about reproductive health, health promotion is a big deal, keeping good nutrition, making sure that we are healthy weights, all that kind of stuff, which is kind of the general thing for all body systems to work properly. But education is also a big thing here. We need to educate students and adolescents about this whole idea of sex and reproduction, and this could be due to also looking at different types of contraceptives that are out there available for them. But of course, the main way to prevent any STDs or any chance of pregnancy is abstinence. Now, the secondary part of this is going to be more of the prenatal care, taking care of the mother as the baby is developing. Blood test screenings are part of this. We also see that they would do the ultrasounds in order to watch and screen for potential issues. Some other things we would look at are going to be with the pregnancy related conditions and complications. We would look at different medications. A lot of times you're given a list of what medications you can and cannot take while pregnant. We would also want to look for gestational diabetes, preeclampsia, premature cervical dilation if you're dilating too early or if the water breaks too early. We would also want to do treatments for pregnancy-related conditions and complications if at all possible. This is going to also help with fetal monitoring. If we notice something in the fetus that we can work on or correct earlier on before the baby is even born, we'd want to monitor that, or come up with a plan for when the baby is born to address those issues. We also see education and support is super important, okay, even with pregnancy that takes place. And assisted reproductive technologies. We talk about assistive reproductive technologies. This is really important for individuals who deal with infertility. There's a lot of different things out there due to just like hormone increases. This could be the whole idea of in vitro fertilization, artificial insemination, all these different things that could potentially help with somebody being able to conceive a child and also carry a child to full term. And the last one here is abortion. All right, so let's talk about some things that happen or that are a problem when we talk about reproduction. And one is menopause. Menopause is not really a problem, but it is a natural halting of menstruation. It is a normal process that does happen as women age, and it happens normally between the ages of 40 to 50. Now, what are some symptoms of somebody who's going through menopause? Well, they tend to have hot flashes, night sweats. They'll have vaginal dryness, which can be addressed and may need to be addressed, especially if they continue to be sexually active. Depression, sleep disorders, decreased libido, increased risk of cardiovascular disease, and osteoporosis. Now, the last two are kind of the main issues here, guys, because due to estrogen levels dropping so drastically, it does put the woman at a higher risk of developing higher cholesterol, which in turn raises blood pressure, clogs up arteries, causing cardiovascular problems. Where men tend to see this a little earlier, women are kind of hold it off a little bit due to those extra levels of estrogen. Osteoporosis is the same way. As estrogen levels start to decrease and they plummet, actually, we see the bones have a harder time being able to use the calcium deposits and leaving the calcium in the bones. And so it causes the bones to start to be weakened, and it causes complications of osteoporosis. So what are some treatments that we see with menopause? Well, we mostly want to treat the symptoms. Since this is like a natural process that takes place, we're just treating mostly the symptoms in order to help them feel more comfortable and to prevent those cardiovascular complications or osteoporosis. However, there are some menopausal hormone therapy that's out there where they could use some artificial type or man-made type of estrogens, but that's just going to sustain and kind of prevent some of this stuff from continuing to happen when it needs to kind of take place with its natural occurrence. Another type of issue that we see with reproduction is seen in males, and this is erectile dysfunction. This is also known as impotence. It's the inability of a male to achieve or maintain an erection sufficient enough to complete sexual intercourse. Now, this affects half of all men who are over the age of 40. And this is normally due to a vascular insufficiency to the penis itself. This could be an endocrine disorder where hormones are not helping in this process. It could be due to drug and alcohol abuse that this insufficiency of blood is occurring. It could be a neurological disorder, spinal cord injury, or it could be a urological disorder. Sometimes, though, impotence or erectile dysfunction could also be a psychosocial factor that is influencing it. If the man is depressed, stressed, has some sort of guilt they're dealing with, sexual anxiety, sexual trauma, or a disagreeable relationship that they're in, it will affect their performance. We do see there is actually a strong relationship between erectile dysfunction and cardiovascular disease. Because this is a vascular insufficiency, if the male is also dealing with high cholesterol, high blood pressure, and even angina, which are precursors to heart attacks, they would be at a higher risk of also experiencing erectile dysfunction. Now, treatment is going to be based on their cause. It could just require the individual to do some stress reduction or do some things like that. But in severe cases, it could require a penile implant that would help with being able to get an erection and sustain an erection. It could be needing a use of an external vacuum device. This would help enlarge the penis, bringing blood to the area to help with erection, or injections of vasodilators. This will then allow for more blood to come into the penis area and cause the erection to take place. All right, the last thing I'm going to talk to you guys about today are sexually transmitted infections, also known as sexually transmitted diseases. A lot of times they're mostly infections if we're looking at the point that they can be treated, okay? And diseases are those that kind of stay around and are more chronic. They can't necessarily be treated and removed. Now, infections can be this is any kind of infection that's transmitted through sexual contact, okay? So it doesn't have to just be intercourse. It could be even through like oral sex, that sort of thing. Any kind of sexual content. Any kind of sexual content where body fluids are part of this. Now, these infections could be protozoa. These could also be different parasites. When we talk about parasites, this might be like a type of lice, that sort of thing. Viral infections and bacterial infections. And viral and bacterial infections are kind of the more common that we hear about, but it could be any of these. It could also be a fungal type infection if we're talking about certain kinds of yeast infections that could take place. Now, some of these do require medical attention, whereas others are a lot of times asymptomatic. Now, even though they're asymptomatic, they may need medical attention. Most of the time, if you're asymptomatic, you're still able to spread that to other individuals. This is one reason why we want the history, and we talk about sexual history, to see how many partners you've had, because if you do have an STD or an STI, we need to contact those individuals because they may have been exposed. If we look at an acute type of infection, the acute infections are the ones that are very kind of short-lived. They may need some actual medical attention to help get rid of them through like antibiotics or antivirals or certain kinds of medications. We do see, though, if they become chronic can cause some major issues like scarring within the reproductive areas. This could also affect fertility. One complication that happens a lot of times when we talk about chronic or even sometimes acute infections, if they are very severe, is pelvic inflammatory disease. This is going to affect males and females, but females tend to see more of the complications with the infertility that comes with that, because it causes a lot of scarring to take place in their reproductive organs. Okay, so when we look at this, guys, there's all kinds of different types of sexually transmitted diseases. You have things like syphilis, which is bacterial. You have chlamydia and gonorrhea, which are bacterial. Those can be treated with antibiotics. On the other hand, you have some viral ones when you look at like genital herpes or warts, and those stay with you always. When you have a viral infection, we can't get rid of those. And so what we're trying to do is keep symptoms down and also prevent you from spreading them when we're doing certain kinds of treatments. All right, so sexually transmitted infections are a big deal, and this is where education comes in as a big help when we're talking about this with individuals, so they understand how these are transmitted and what the complications could be from them. All right, so if you have any questions or concerns, please let me know.